Salams to everybody who's joined us today. We are very, very excited to kind of present our women's sexual and reproductive health across the lifespan webinar. I know that our presenters and our team, including Iman and Sana, have been really working hard for a couple of months now to make this happen. And so I'd like to introduce myself. I'm Firdaus Ali. I'm the programs manager with CCMW. And if we can just go to the next slide, please. So we have a simple agenda for today. We hope to be with you from 7 to about 8:20, 8:30. And we will start with land acknowledgements. We'll get to know our presenters for today. And then our session will begin with an introduction to sexual and reproductive health, hormone health. And then once we finish with the presentations, we will have questions from all of you. So I would just say that if you have any comments, feel free to put it in the chat. But if you have questions related to the presentation today, I would just say hold off and we will answer them during the Q&A session. Or you can put it in the Q&A towards the end of the session. So if you can go to the next slide, thank you. So I'll just begin with the land acknowledgements. And again, a big, big welcome to all of you. And we will talk about why we planned to hold this session today. But I would like to begin by acknowledging the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 within the Mississaugas of the Credit, and we honor the lives of the missing and murdered Indigenous women and girls. And by offering this acknowledgement, we commit ourselves to continuous learning, standing in solidarity with Indigenous women, and doing the necessary work to dismantle ongoing colonial harms. Next slide, please. So I think that you may have questions as to why we have a session like this today, and really wanting to let our members know that, we as women, as racialized women, sometimes do not find avenues to talk about sexual health, reproductive health. We have so many questions ranging right from the menstrual cycle to menopause, but don't know where are these avenues, where do we get this information? And I attended a CASA session maybe a couple of months ago, and I found Dr. Anne Hussain, who's one of our presenters, and someone from Action Canada presenting. And I was really, really happy to be part of that conversation and to find such a safe space where I could, learn and share with each other. I come from India, from Bombay, and as a teenager, I didn't know whom to ask about irregular menstrual cycles. I really had nobody to go to. And then 35 years later, as I was going through menopause, I really had a male doctor, and the discomfort of discussing how your body is changing, the hormone changes that are happening, the hot flashes, the mood swings. Really, really difficult to talk to a male doctor. And again, you find yourself siloed. And I feel that as a women's organization, we really talk a lot about many things that are happening to us. We are delving into mental health, but somehow sexual health takes a backseat. Sexual and reproductive health takes a backseat. There's a lot of stigma still around talking around it. And we thought that, as an organization committed to equity, to equality, and empowerment of Canadian Muslim women and girls, this is such an important conversation. And I hope that it is the first such conversation of many that we will have together to create a safe and informative space for learning, discussion, and community engagement. So today, our goal is to explore key sexual and reproductive health topics relevant to Muslim and racialized women, and provide an opportunity to ask questions to our presenters and our experts. Next slide, please. And as I introduce our speakers, I just wanted to also add that, you can add information to the chat, but reserve your questions to the end. And again, a big welcome to all of you. And I'd like to introduce Nafisa Rahman, who goes by the pronouns they and them. So Nafisa is a Toronto-based community worker, passionate about the intersections of sexual health, disability justice, and youth engagement. driven by their experiences navigating their sexual health as a racialized queer youth in Scarborough. They have dedicated the last 10 years towards direct client support, sexual health education, and community programming. Nafisa started their journey at Action Canada as an access line navigator and has recently moved into the health promotion coordinator role, where they oversee the access line program. In their spare time, they enjoy gaming, journaling, and trying new places to eat with their friends. Nafisa, that's something you and I have in common. So, welcome to our presentation, and we are so happy to have you here. Our next presenter is Mariam Dakduki. Mariam goes by the pronoun she, elle, and Mariam was born and raised in Montreal and now lives in Ottawa on the unceded, unsurrendered territory of the Anishinaabe Algonquin people. Mariam has worked in the sexual and reproductive sector since 2018, supporting individuals in their health journeys. She currently works as an access line navigator with Action Canada, providing emotional support and system navigation services, and ensuring community members feel informed and advocated for. Mariam prioritizes access to compassionate, comprehensive care and supports people in making informed decisions about their bodies. Thank you, Mariam, and a big welcome to you. Our last presenter for today is Dr. Anne Hussain, who goes by the pronoun she and her. And like I mentioned, I met Dr. Anne virtually at a CASA seminar, very impressed with what she has to offer. And I think she's among the few women that I heard talking about menopause and perimenopause. So very excited to have you today, Dr. Anne. Dr. Anne Hussain is a naturopathic doctor, Menopause Society certified practitioner, and a TEDx speaker, and author of the Period Literacy Handbook. Her personal experience navigating a lack of reproductive education growing up in Karachi, Pakistan, informs her commitment to empowering women with evidence-based care throughout all stages of their hormonal health. With over a decade of clinical experience, she focuses on period, PMOS, which she will describe to us in detail, and the perimenopause education, delivering science-informed guidance to both patients and clinicians. She also hosts Face to Face, the Hormone Health Show, and works with Canadian health equity organizations to advance public education and awareness in hormonal health. Welcome to you, Dr. Anne, as well. So without much ado, I'd like to kind of hand it over to Mariam and Nafisa to walk us through Action Canada's wonderful website and the resources they have around sexual health and rights. Thank you.
Amazing. Thanks so much for for the introduction and for, of course, having us here today. Hi, folks. Again, my name is Nafisa, and both Miriam and I work at Action Canada for sexual health and rights, specifically with the Access Line program, which we will talk about in a little bit. But yeah, we'll go over a little bit of who we are, and then we'll cover a few different sexual health topics. Can we go to the next slide? Perfect, thank you. So a little bit about who we are. Action Canada for Sexual Health and Rights is a progressive human rights-based charitable organization committed to advancing and upholding sexual and reproductive health and rights in Canada and globally as well. Our vision is that all people everywhere have full control over and are able to decide freely upon all matters related to their sexuality, reproduction, and gender, including their reproductive and sexual health. And so our organization is very much advocacy forward, but our Access Line program is sort of one unique frontline service program that we offer. But it is very much advocacy first. And the four sort of pillars of our work include abortion care, contraception, comprehensive sexuality education, and just generally sexual and reproductive health and rights advocacy. Next slide. Thank you. Now I'll pass it over to Miriam.
Thank you, Nafisa. So our access line is basically the type of work that Nafisa and I are doing day to day, and it will be what people encounter when they reach out to Action Canada. So it is a program that runs a free confidential support service so people can ask questions about sexual and reproductive health. So people can contact us by phone, by text, or by email. And our access line is open 7 days a week from 9 a.m. to 9 p.m. Eastern. So we're providing information, answering questions, offering support and referrals to sexual and reproductive health providers, so any clinics, but we don't provide any medical information or offer advice or long-term counseling or therapy. We're also not a crisis line. We do have people that will call us in crisis, and if that ever happens, we are always in a position to connect people to other services as well. In addition to navigators that speak English and French, we have navigators that speak Arabic and Bengali, and we also have access to interpreters in over 230 languages. So we always say don't hesitate to reach out, no matter what language someone speaks. And then next slide, please.
Perfect. So Miriam went over sort of a bit about the Access Line program. I'll cover here just I will say that like folks do call in with like questions about all kinds of topics related to sexual health. Here, what we have listed are some of the more common topics that we get. Most often, it's really around pregnancy options. So folks are sort of reaching out to us wanting to know more about what parenting is like, adoption, as well as abortion services maybe in their area. Often they want referrals to clinics or providers. That's something that we're more than happy to help with. And of course, the emotional support piece for anyone who might be feeling overwhelmed by a pregnancy and just needs to sort of talk to someone about their options. Another area is sexually transmitted infections or STIs for short. So often we get folks reaching out that are concerned about transmission risk, just have general concerns about STIs, would like some sort of risk assessment by talking to us, and often would like referrals to where they can go to get STI testing. And then, yeah, of course, pregnancy. So just broadly wanting to know about like pregnancy testing, again, risk assessments, like, am I pregnant? Am I not? How do I find that out? Again, referrals on where they can go for testing as well. And then pregnancy options counseling, which I mentioned earlier. So just wanting to talk more about what their options are looking like. And then the last big topic is just contraception. So just the types that exist, how to access them, how to use them, and then emergency contraception in particular. Thanks. The next slide.
So on this slide, we wrote out some of the population groups, so people that will contact us. But essentially, our services are available to anyone and everyone. So most callers will actually call and speak to us anonymously. We don't ask for any identifying information, as well as any information that people are not comfortable sharing. People can call us, text us, and tell us as much as they want to, and we'll go from there. We support people from all types of backgrounds and lived experiences, and our services are always non-judgmental, compassionate, and culturally informed. So what that means is we're always trying to support people in whatever choices and beliefs that they hold. So even if, people are against certain types of sexual and reproductive health topics or feel like it might not be the best fit for them, we're always happy to support them in whatever they are most comfortable with. Next slide, please.
Perfect. So we'll dive into a couple of sexual health topics. We'll start off with contraception. So when we say contraception, we're talking about methods to prevent pregnancy when having sex. So here we mentioned that people can become pregnant when having unprotected penetrative penis and vagina sex. And we do want to clarify that, words like penis and vagina might not be words that everyone uses for their own body or words that resonate with them. We're using them here because they're just more commonly known, but we do encourage folks to just use the language that feels best for them. And so In terms of how pregnancy happens, to be able to get pregnant, sperm must enter the vagina and then swim up into the uterus and fertilize an egg that's been released from the ovaries during ovulation. So what contraception does is that it's stopping this process from happening in a few different ways, depending on the type of contraception. And then some forms of contraception can also protect against STBBI transmission, or STI transmission, so sexually transmitted infections. Another word that folks may commonly use is birth control. So you might see that a lot in resources or when you talk to your healthcare provider, but they're sort of mean the same thing. There are many options out there for contraception. Each method, has their own different benefits and drawbacks. There isn't one like method that works for everyone. And often when people are calling our line, they might be asking, hey, like what method is best for me? What would you recommend? And, again, our line can't offer any medical advice, or diagnosis or anything like that. Because every method, will work differently for each person. We can go to the next slide. Thank you.
So on this slide, we have a little bit more information about different types of contraception. So on the left-hand side, we have the different categories that contraception or different types of birth control are placed under. And then on the right-hand side, you'll see different actual types. So very common types of contraception. So if we start with the categories, the first one and usually the most utilized is a hormonal method. So it's preventing pregnancy, usually by affecting the hormones. Very, very common. So you might have heard of things like the birth control pill, a patch, a ring, the Depo-Provera shot, an implant. So the next plan on implant that goes in the arm, and then the hormonal IUD. So sometimes called the Kyleena or Mirena, that's the brand name of it. But those are the kind of most common types of contraception. The second category is non-hormonal methods. So ways of preventing pregnancy that don't involve hormones, becoming more and more popular nowadays, but it includes things like a copper IUD. So also very common condoms, so both external and internal condoms, VCF, which is vaginal contraceptive film, diaphragms, and then there are more behavioral methods. So something like a fertility awareness method, which is when someone will track their cervical temperature and their ovulation to make sure that they are either using another form of contraception or using another behavioral method, withdrawal, which is pulling out around times when it's riskiest for them. So things like FAM and things like withdrawal also count as forms of contraception. I do have some forms of effectiveness against preventing pregnancy. With non-hormonal methods, specifically for condoms, those are the only contraception method that protects against the transmission of STIs as well. So you have kind of two benefits there, preventing pregnancy as well as STI transmission. The third category is permanent methods. So these are surgical ways of preventing pregnancy and mostly referred to as permanent. There are some ways to reverse some of these, but it's never a guarantee. So that's tubal ligation for people with ovaries and vasectomies for people with testes. And then the last category is emergency contraception. So both hormonal and non-hormonal, but most commonly is the emergency contraception pill, so the Plan B pill, and then a copper IUD or even a hormonal IUD can nowadays be used as emergency contraception as well. Next slide, please.
Perfect. So, what are some factors that folks are considering when choosing a method? That's something that we often talk to folks about on the Access line. Here's just a list of a few reasons, but of course, like everyone's life circumstances are different, and you individually might have different factors that you're considering. Some examples are, of course, like the effectiveness of the contraception method, any potential side effects, the cost, the coverage of health insurance. So whether or not your health insurance will cover the contraception method that you would like, personal values, culturally, religiously, politically, how often it needs to be used and how, when and if, a person would like to have children. And then, of course, like where can people go to access contraception? That's like another question that we often get. But of course, a family doctor, if you have one, a lot of folks don't have one. But that is one option if you do. Walk-in clinics, like any like general physician, should be able to prescribe contraception methods to you if it needs to be prescribed. Sexual health clinics as well, that specialize specifically in sexual health, oftentimes have contraception methods that are lower cost as well. And then pharmacies for more so like over-the-counter contraception, such as Plan B, or condoms. Those can just be found in like a drugstore.
So that was kind of the end of the contraception section. Like Firdaus mentioned, if anyone has any questions, if you could write them down somewhere, just kind of keep them to the end, and we'd be happy to answer questions then. So the next topic we'll cover is STBBIs, also known more commonly as STIs, which are sexually transmitted blood-borne infections. So STIs can pass from one person to another through blood or other bodily fluids, primarily through sex, and that would be vaginal, anal, or oral sex. Common types of STIs include chlamydia, gonorrhea, syphilis, genital herpes, also known as cold sores or HSV, and HPV, human papillomavirus. So anyone who is sexually active can get an STI and transmit it. It also is very, very common amongst the adult population. So most people who are sexually active in their lifetime will have an STI at some point in time. Many people who get STIs actually have no symptoms. And so they might not know that they have an STI. They might not know that they're transmitting an STI unless they get tested. It's recommended nowadays in Canada that people who are sexually active get tested at least once a year. So practicing safer sex, getting tested regularly, and getting treated when needed, those can all lower chances of getting or transmitting STIs, and those will reduce long-term impacts on people's health.
Great. So, like Maria mentioned, STI transmission is, easily preventable through education, testing, the use of barrier methods like condoms. However, there has been a recent trend of several STIs being on the rise in Canada in recent years, primarily due to a falling rate of condom usage. So that's just some information for folks to know. And like Miriam said, like, honestly, like the most common STI symptom is no symptom at all, which is why folks, will suggest that you get tested if you're not sure. But some symptoms that might come up, and the ones that we have listed here aren't specific to any certain STI, but might be symptoms that you may notice. Things like unusual discharge, painful urination, sores, bumps that you might not have noticed before. Itchiness, redness of the genital area, and these are just, a few of them. But these can be signs, and if you ever are noticing them, it's best to speak with a healthcare provider about that. There are a few different types of tests that exist. So let's say you are worried and you go to your healthcare provider wanting to know whether you have an STI. It's likely that based on your health history, they are going to suggest a few different types of tests. The ones that are listed here are like a urine test, blood tests, swabs, and then a visual exam, meaning like the healthcare provider will just take a look at like maybe a sore or bump to kind of determine what it may be. And then window periods are, and you might see this in different resources, but it's the amount of time that needs to pass after sexual contact and before you can expect an STI test to be accurate. So, there is some time after, having sex where you might need to wait before you can test for an STI and for the results to be accurate. And the window period for each STI is different. And let's say that you did get a positive test, like some STIs are curable with antibiotics in terms of the types of treatments out there, while other STIs are just treatable and or manageable. So you might be prescribed pills or ointments or creams to be able to manage some of the symptoms that come up with an STI.
Thank you, Nafisa. So the last topic that we're covering today is pregnancy options. So I would say as someone who covers our line, which means I'm answering phone calls, I'm answering texts and emails, contraception, STBBIs, and pregnancy options are what most people will reach out to us for. So questions about these three topics. When we talk about pregnancy options, it's essentially the options that exist when someone finds out they're pregnant and they're kind of thinking about what they want to do with that pregnancy. So the first one is parenting. So carrying a pregnancy to term and ultimately going through labor and raising that child. So common calls and questions that we'll get about that is, I'm pregnant, I don't have a family doctor, where can I access prenatal care? Or, for example, if someone is in Ontario and is a newcomer, so they don't qualify for OHIP just yet, they don't qualify for a provincial health card, they might ask for support with finding free prenatal care. That's something that we will often do. So labor support as well. So getting connected to a labor support provider like a doula. We have connections with a lot of partner organizations, with a lot of providers, and can be helpful there. And then the last thing is testing or imaging. So again, if some people are thinking that they might be pregnant, but they're just not sure, how do the pregnancy tests work? Where can they access pregnancy testing? How soon after having sex can they know if they are pregnant or not? Those are kind of common questions that we'll hear. The second option is abortion. So that is just a medical process to end a pregnancy. And there are two types of abortions that exist. There's the medication, also known as the abortion pills, and there's procedural abortions. Abortion is legal, it's safe, and it's very common in Canada. So some questions we get is, where can I get an abortion? How much will it cost? But also, we emotionally support people that are finding themselves making that decision. We fully understand that it is a very difficult decision for some to make, and we have a lot of compassion for that. And so we can connect people with providers, of course, but we also can hold space for those conversations of having to make that decision. And sometimes some people feel like it is the best decision for them in that moment, but it's not the decision that they want to be making. And then the last option is adoption. So carrying a pregnancy to term and legally transferring parental rights to another person or family. Of the three pregnancy options, we do definitely get adoption the least amount. But common questions are how the adoption process works, or wanting to get connected with a values-aligned adoption worker. So someone who's very compassionate and non-judgmental, and we will connect them to either an agency or a worker.
Great, thanks, Maria. And so the last thing we want to leave you folks with is our contact info. We know that we've only very briefly covered a couple of sexual health topics, and you might have a lot of questions that might not be answered today, but we do really encourage folks to contact our access line. Again, we're open 7 days a week from 9 a.m. to 9 p.m. Eastern Standard Time. You can do it by phone at 1-888-642-2725, or by text at 613-800-6757, or by email at access@actioncanada.shr.org. Again, we can answer questions, provide information, connect you to a provider. We also offer peer counseling services concerning sexual and reproductive health topics. Our services are anonymous, non-judgmental, and culturally informed. We do respect all callers' beliefs, values, and decision-making processes. So feel free to reach out if you have any other questions.
Thank you, Mariam and Nafisa. That was great. I think it was more like a one-on-one, but it kind of intrigued us, and I'm sure that our attendees have several questions and want more discussion. I just wanted to add today that, we had done a little survey with our own members to know what they'd like to see in today's presentation. So apologies, I did forget to mention that the topics that are being covered today are basically on the survey findings that we had, which you told us, our members, that, we want to know more about contraception, we want to know more about STIs, and on pregnancy options. So I hope that we can have a second session before the year ends, kind of to delve a little more deeper into this. And I also wanted to add that, my own work in the HIV/AIDS sector more than a decade ago, it brings back a lot of the informed learnings. Everything that you're saying comes back. And I think sometimes it's a myth and a misconception that, this is not happening to our communities, or we are not impacted, we are not affected. But again, I would like to say that having worked in the sector for almost 10 years, just to let you know that these are not myths and misconceptions. We are all impacted by what happens around sexual health, not only to ourselves, but to those in our families. And having that informed choice, having that choice itself, and having it informed and educated choice really empowers us to lead healthier and better lives. So again, I'd like to thank both of you for this amazing presentation. And I'd like to now switch gears a little bit to invite Dr. Ann Hussain. And I don't know that in our membership, and again, with the attendees that we have today, there is some diversity in age as well. So, while we spoke about the menstrual cycle or contraception, STIs, we also have a lot of women my age, slightly younger, who really have sometimes no avenues to talk about perimenopause and menopause. I myself was one of them. And really, where can we have these discussions? Where can we have such virtual and other spaces to talk about this? Many a times it's our own family that does not understand the changes that our body and our temperaments are going through, but there is a cause for it. And really, Anne would take us through this. And we will also talk about tips and tools for hormone health. So, Anne, take it away. And I know you did an amazing job with the CASA presentation. I was so impressed, and I got you here. So, thank you for being with us today. And I hand it over to you.
Thank you so much for inviting me and having me. And thanks, Mariam and Nafisa. That was a great presentation. I'm so happy that organizations and resources like you exist. Hi, everyone. Assalamu alaikum. We're going to start by talking about menstruation in general. And this my portion of the talk was advertised more toward perimenopause and menopause. So I do want to make sure we spend a decent amount of time on that. But in order to do that, we need to talk about menstruation and we need to talk about hormones in general. And in the survey that was circulated, general hormonal health was a common topic that kept coming up. Hopefully, I can come back and speak a little bit more to that specifically or other topics that come up. So, this is what I always say, and this is sort of my origin story of why I do the work that I do, is that when we don't know what normal is, we also don't know what abnormal is. And with menstrual health, reproductive health, sexual health, this is the case that oftentimes happens for many of us. I grew up in Pakistan. We didn't have any formal sexual health or reproductive health education. My period came as a surprise. And years later, my cycles were really irregular. Sometimes they would go missing for months on end, and I did not know that that was not normal until I started learning about biology in undergrad. So I want you to just remember that when we don't know what normal is, we also don't know what abnormal is. And this is where education can be so empowering to so many of us. And I highly encourage you to get more information about your body to the best of your ability. So, a menstrual cycle, there's no one singular experience that is like the optimal experience. There is a range in experiences that is considered normal. Menstrual blood loss can happen over 2 to 7 days, all considered normal. And average blood loss tends to be around 30 to 50 milliliters, which may not mean anything to you at all if you're using period products. So depending on the product, if you use a cup or a disc, which is typically inserted into the vaginal tract, that will have volume markers on there. But menstrual blood always contains more than blood. It also has mucus. It also has immune cells. It has different types of compounds in it, which can boost the volume that you're seeing. And it can also have clots in it. So 30 to 50 milliliters, generally speaking, over the span of a period may look like 1 or 2 heavier days where you're changing your pad, like an absorbent product, like a pad or a tampon, for around three-ish hours. Anytime you are experiencing bleeding where you're changing your period product because it's saturated or you're leaking or you're flooding and you're changing that every hour, that is considered heavy bleeding, and that is not normal. It should be investigated. If it's a one-off, it's different. But if that's your normal, that we should be investigating to see if there's anything that is causing that or contributing to that. The things that we'll come to a few conditions that can contribute to that in a few slides, but most periods really should be fairly painless, as in you can experience some discomfort, you can have some heaviness or downward pressure, you might experience a little bit of change in your bowel movements even, so your stools might be a little bit softer, or you might have some urgency. Those changes are considered normal. You might even feel a little bit tired, but anytime you are taking heroic doses of medications to manage your pain, anytime you are missing out on life, school, work, or other activities, that starts to encroach into the territory of not normal. Okay. Most of us don't really learn what normal is. And this is why I wanted to start here. And unfortunately, doctors are humans, which means that they sometimes think that those sorts of symptoms are normal, especially if they haven't really been keeping up to date on some of the diagnoses that contribute to these conditions. A cycle length that is considered normal. So a menstrual cycle is defined by period day one, so first day of your flow, to the end of to the beginning of the next cycle or the next first day of flow. So when someone asks you about cycle length, we're not talking about the length of your period. We are talking about the length of the full menstrual cycle. So from your bleed to the next bleed. And that should be around 24 to 38 days once established. And by once established, I mean after the first couple of years of your period starting for the first time ever, that's when you should really have a regular rhythm to your flow. And then until perimenopause. So in perimenopause, we can now start to see longer cycles. And that is actually how we define perimenopause, by changes in menstrual cycle. Get to that in a second as well. But throughout our premenopausal years and post-menarchal years or post-pubertal years, we really should be seeing a 24 to 38 day cycle. 1 or 2 days off every cycle is not a big deal. That is not what's considered an irregular cycle. So let's say, I'll give you my example. So my cycle tends to be 31 days. Some cycles, it is 30 days. Some cycles is 32 or 33 days. That's considered normal. Your cycle does not have to be 28 days. 28 just happens to be the average, and also typically the median number that happens most often. Cervical mucus is one of the things that that actually Mariam brought up as a fertility awareness-based method earlier in the presentation. So cervical mucus is discharge that we make throughout our cycle. Most of us are going to notice this in the middle of our cycle around ovulation time. So what happens when our cervix, which is part of our uterus, is exposed to estrogen, which is our primary sex hormone. Estrogen causes your uterus to make mucus. So the specific part that's making it is called the cervix, and that's why you might actually notice a little bit of discharge throughout your menstrual cycle. I've had many patients come to me and thinking that they cyclically or every month they have a yeast infection or they have a vaginal infection, because they actually, what they're noticing is cervical mucus. So cervical mucus tends to be clear. It tends to be off-whitish, whitish, or maybe a little bit opaque. So it doesn't have to be clear. Generally speaking, it'll start as a little bit, and then it will increase in volume, and it might become stretchier or stringier, or you might notice it more or slippery. And then it starts to get tacky or dry again after you ovulate, and then you might not notice any at all. We all make different amounts of cervical mucus, and there's no one correct amount to be making. That is very different than a vaginal yeast infection or bacterial vaginosis, in which case you typically have symptoms of burning, itching, and discharge that is not clear, but maybe white, crumbly. In the case of yeast infection, it may be greenish tinged or really yellow in the case of bacterial vaginosis. Okay. Now, as you get closer to your period, you may experience some premenstrual changes. So this is in the lead up to a period. And this happens oftentimes due to natural hormonal fluctuations. So mild premenstrual symptoms before a period can look like mild breast tenderness, feeling a little bit sluggish, appetite increase, a little bit of water retention. Some people break out or their skin reacts. Mild symptoms are considered normal, but anytime those are interfering in your life or severe, then we go into the territory of either premenstrual syndrome or PMS, or if they're extremely severe and disruptive, we're going into the territory of something called PMDD or premenstrual dysphoric disorder. I'll talk about that in a minute. So I want you to really focus on that bullet point that says none of the above should interfere with daily life activities, because menstruation is a normal and natural part of life, part of our health. It can go away if your resource availability is low. So let's say you go through a tremendous amount of stress. Let's say you are not getting the fuel that you need. Let's say your immune system really took a big hit. These are cases in which your body deprioritizes reproduction in to prioritize survival. In that case, you may lose a period. So having a regular period actually is a sign that your body is physiologically doing what it needs to be doing, even though sometimes some of us may not want a period, for example, and there are options for that from a contraceptive standpoint. The last point on this slide is periods change over time, and truer words could not be said. Periods change from the time you get them until the very end, and those sandwich years, like the end year, beginning years and the end years, tend to be the most the ones with the most change, essentially. Now, menarche is called the first period ever, typically happens a couple of years after breast development and puberty, and the average age is decreasing over time. So we're seeing younger and younger ages of people who are getting periods. And then, but the average age tends to be around 10 to 12. And then menopause is the 1 year anniversary of your final period ever. So let's say you have your final period ever today, and then you don't have a period for 12 months. Next year, on July 17th, 2027, you will have reached menopause, and then forever after that, you are postmenopausal. So that's how we define menarche and menopause. I wanted to give you a brief overview of like all the changes that are happening. And these are not all the changes at all. These are only a fraction of the changes that happen in the body. This is for an illustration from my book called The Period Literacy Handbook. But on the left side are parts of the brain. So you have the hypothalamus pituitary gland. So those are the first two organs. And at the bottom, you have your ovary. So the menstrual cycle happens when there's communication happening between those organs, but it doesn't, even those organs don't work within an isolated system. All of your life and health and your other systems in the body will influence this communication system. As you can see, the top graph on the right is your FSH, so follicle stimulating hormone, and LH, or luteinizing hormone. And those are very different profiles if you look at them. So your LH is the hormone that you make to trigger ovulation. And that hormone is really sensitive to estrogen levels. It is sensitive to, like I was saying, resource availability. It wants to make sure that you're able to reproduce, essentially. And then FSH, or follicle stimulating hormone, is the hormone that tells your menstrual cycle to sort of reset every cycle and recruit eggs to be recruited for the next cycle. And that FSH number starts to get higher and higher and higher as we get older. At the bottom, you'll see estrogen and progesterone. So estrogen increases at the beginning of the cycle, then takes a little bit of a dip. And then if you look at the second half of the cycle, this tends to be the most symptomatic time for people, and it's because both hormones, estrogen and progesterone, they go up, and then there's like that wild decrease that happens when the body recognizes that fertilization of the egg or pregnancy did not occur. And that change in hormones can really affect how you feel, and each of us can have a different sensitivity to that change in hormones. So if you look at that graph, estrogen and progesterone both can fluctuate quite differently throughout the menstrual cycle. And even though we think about testing as a really objective measure when it comes to your iron levels, your thyroid, your B12, your cholesterol, when it comes to hormones, testing doesn't tell us as much as we would like it to, because we can't oftentimes draw a straight line from an estrogen level to a symptom or your progesterone level to a symptom. And this is why hormonal health oftentimes is really difficult, especially because we have to believe the women who are sitting in front of us. We have to believe the menstruators sitting in front of us and what they're saying. So hormones will change over your lifespan, and your response to them also changes over time. But first, I want to go through how periods change over time. I know I briefly touched on this, but I didn't talk really about what happens if there is pregnancy in the middle. So menarche is your first period ever. Cycles can be irregular for 12 to 24 months, but they should regulate after that. So in the first couple of years of having a menstrual cycle, the reason why it's normal for there to be irregularities is because your brain and your ovaries have been put on hold while your body grew between the ages of 0 to 12, for example. So we actually put a pause, or it's called a neurobiological break in your reproductive function while you develop, your brain develops, your body develops in those first 12 years of life, and then your brain and ovaries start to connect and communicate with one another. It takes a little bit of time. I always describe it like making a new path in the forest or in grass. The first few times it's unclear, but as you tread on it more and more and more, your body learns to do it more effectively. So that's kind of what it's like. Your body will learn how to do it more effectively. There can be barriers, genetic or different conditions that can lead to that, but for most of us, that should regulate fairly quickly. Cycles can change from your teens to your 20s because we actually reach reproductive maturity around 8 years after our first period ever. So reproductive maturity, if your first period was 12, you reach it at around 20. That's when we call you reproductively mature, as in all the parts of your reproductive system now are at their adult level. From your 20s to 30s, there is change. And even if we think about fertility, this is going to be peak fertility somewhere in there in the mid 20s when egg quality is excellent. Most of the time, again, there can be conditions that contribute to poorer egg quality, but 20s to 30 is prime fertility time from an egg quality and reproductive standpoint. There can be changes between your 30s to your 40s, and oftentimes toward the end of your 30s, you may be entering perimenopause. So you can enter perimenopause earlier than you think in your late 30s. And then 40s to 50s is the most common time when people are going to be experiencing perimenopause. Perimenopause can last a long time, even a decade. So it doesn't mean that it happens all at once. It happens slowly and it manifests in different ways. The changes in your cycle can happen for a variety of reasons. Some of it is because we're reaching reproductive maturity. Some of it is lived experience. Some of it is how our genetics are wired, what is happening in our life, circumstances, your postal code, and then also what else is happening in your health. When you're pregnant, there is no period for an approximate time of 9 months. Periods can change slightly after pregnancy. Pregnancy can sometimes bring along positive changes in a period after you're done, or it can sometimes bring not so welcome changes. But there's no standard there. You really have to get to the other side and see what happens. The most common time that people will get a period postpartum is around the 8-week mark. Breastfeeding, if someone is producing milk, then periods can be regular or they can be irregular. Part of this is because your hormones change, which means that you might ovulate irregularly. Ovulation is how we essentially create a regular period. If you don't ovulate, or if you ovulate irregularly, and ovulation is when you release an egg, then your cycle could be absent or delayed. So ovulation is what dictates the length of your cycle. If you ovulate on cycle day 14, you will get a period on cycle day 28. If you ovulate on cycle day 20, you are going to have a period at around cycle day 32. So that's why sometimes when people have irregular cycles, we want to regulate it because we know that they're not ovulating regularly. Breastfeeding is an exception because it's happening because of hormone change. That is very natural and inherent to the process of lactation. Now, perimenopause are the years leading up to menopause. And I'm just gonna hold off on that and talk about it in the other slide. And then menopause is when we officially reach our final period ever, 12 months after that. I put this slide in because I think we think of hormone health all as something that we have influence over and something that was either happened to us or something that we can really change everything about. And it's a yes and a no to all of that, meaning that your hormones and how you respond to hormones and how your brain responds to hormones and how your body responds to hormones really is multifactorial. Your genetics and how your genetics are expressed while you're in utero, as in while you're a baby, or while you're in the womb, as you age, as you live life, as you get exposed to things out in the world, but also within your families, your experiences growing up, your health changes, all of these things play a role in your hormone health. So epigenetics, for those of you who don't know, epigenetics is how your genes are expressed under environmental factors. So genes and epigenetics are one part of it. Environment, growth, and development are the other part of it, and that includes your postal code, policies, where you are, education, and all of those sorts of things. Because as we know, everything feeds into everything else and nothing works in isolation. Your hormones and metabolic health play a role. So if you have insulin resistance, for example, or you carry a lot of fat in your abdominal area around the organs, all of these things can play a role. Hormones can be affected by environmental exposures as well. Age, medical history, we went through all the age-related changes that can happen, but there are conditions that feed into other conditions and that can change how you experience your health. And then lifestyle, as including, your nutrition, your sleep, your exercise, your hydration, all of the bits, your social connection. All of that plays into your hormonal health. And your hormones really don't respect medical silos. Your hormones aren't only about fertility and they're not only about reproduction. Oftentimes, when younger patients approach their medical team and say, "Hi, I have XYZ, like PCOS, which is now called PMOS, or I have really painful periods, or I have XYZ condition." Oftentimes, when patients are young and they go to their doctors to talk about their hormonal health, their menstrual health, they sometimes are dismissed because we think and are told to come back when you want to have kids, which may or may not be someone's reality. They may or may not want to have kids at the end of the day. So hormones are always about more than just, and say just very loosely, about fertility and reproduction. They affect all parts of you. They interact with all your systems, including your heart, your immune system, your brain, your nervous system, your digestive system. And if you have a body and if you have hormones, I'm pretty sure you all have experiences with that. Now, I've said this a few times, but hormones can really affect us all differently. And I wanted to bring attention to a term that is commonly thrown around quite loosely. And sometimes it really is to communicate something is happening. So this term is hormone imbalance. And the reason why I bring it up is because I have a lot of patients who come in and they say they have a hormone imbalance and they have bought a lot of things or they have spent their time and resources on a lot of things that would be better utilized if they were simply to talk to a medical professional and really have their concerns validated, heard, and then maybe getting an assessment and a diagnosis. Because oftentimes when there's a hormone imbalance, there's something happening, but we haven't labeled it more specifically. So hormone imbalance is thrown around in the marketing world quite a lot to sell you things, but it's also used to communicate that something is happening in non-medical settings. The most common things that are referred to as hormone imbalance include PMOS, which is polycystic ovary syndrome, or it used to be PCOS, polycystic ovary syndrome. The name just got changed in, what month are we in? July, 2 months ago, in May of 2026 to PMOS. So now it stands for polyendocrine metabolic ovarian syndrome. Say that 3 times. But that is a condition in which you have irregular cycles. It's a condition I'm very familiar with because I have it, and half my patient population has PMOS. So this is when we have irregular cycles with a combination of high androgens. So that could look like cystic severe nodular acne, hair loss on the head where we don't want hair loss, hair growth on our body and face where we don't want it, and metabolic issues. So insulin resistance or prediabetes or blood sugar dysregulation, high blood pressure, high cholesterol, these sorts of things are part of that. And then we have other things that can fall in that category of hormone imbalance include endometriosis, adenomyosis, fibroids, and polyps. So period pain is something that is quite normalized in menstruators. And these 4 diagnoses are the ones that are oftentimes related to heavy bleeding and period pain. Thyroid disorders actually, your thyroid makes hormones. Thyroid disorders can also lead to hormone imbalances or symptoms related to what patients say is a hormone imbalance. And that can look like fatigue, hair loss, feeling cold, weight gain or weight loss, palpitations, anxiety. So a lot of the things that we relate to hormone imbalance, it can also be coming from the thyroid, super common in women. PMS and PMDD are premenstrual disorders, so both happening in the second half of the menstrual cycle. PMS is premenstrual syndrome. Premenstrual disorders are essentially severe volatility in mood and nervous system dysregulation in the second half of the menstrual cycle. Then we can have early menopause, POI, which is premature ovarian insufficiency. So you're reaching menopause before the age of 40, which can happen, and perimenopause. So perimenopause, like I said, can last a long time. And when you're going through a lot of symptoms that show up in your mood and affect your energy and affect your focus and affect your sleep and your periods, that would be construed a hormone imbalance or what feels like a hormone imbalance. Infertility falls in that category. So does something called hypothalamic amenorrhea, when your brain shuts off reproduction because you just don't have the resources to mount a menstrual cycle. It's common in athletes, in high athletes. It's common in eating disorders, and it's also common when you've gone through high amount of physiological, immunological, or mental emotional stress. And then nutrient deficiencies can also contribute to how people are feeling, and changes in hormones. Okay, so we finally made it to perimenopause and menopause. So menopause, as I was mentioning before, this is the day when you've gone without a period for 12 months, and not due to any other medical reason. Okay. You can reach menopause, natural menopause for most Canadians, and I'm going to use Canadian data for a second, happens between the ages of 50 and 52. Now, there's some data coming from across the globe, including South Asia, for example, and Africa, where we're seeing a varied range in when people are reaching menopause. And the data isn't great. I'm just gonna leave it at that. We're gonna see a lot more data come out in the next few years that is stratified by population, but menopause is when you've gone without a period for 12 months. I really encourage you to track your menstrual cycles if you don't do that. We're going to get to that in a second as well. Postmenopause is basically life after menopause. That's what we call postmenopause. Perimenopause is the years leading up to menopause. So this is the time when we start to see changes in your menstrual cycles. We start to see changes in a lot of different parts of your body because your hormones affect everything, and it can really last a long time, and there is no singular experience like that is the experience. There is a spectrum of signs and symptoms and changes that can occur in this time, and we all can be impacted differently based on all of the factors that I went through a few slides ago. There's also a term called premenopause, and this is essentially the prime reproductive years, essentially when your periods are, when post-adolescence, when you're in that steady state sort of menstrual cycle time frame. All right. So as you can see here, so this is not an exhaustive list, but it's a pretty comprehensive list. So it has a lot of different signs and symptoms and changes that can occur during perimenopause. Take a read. I'm not going to go through all of them, but what I want to say is that when we approach menopause, so what happens as we get toward menopause is that we essentially don't have as many eggs to ovulate every menstrual cycle. Every cycle, we have a group of eggs that we are recruited, or follicles that are recruited, and the follicles have eggs in them. And then as we age, we lose these eggs. So we actually are born with millions of eggs, and then we lose half of them over time, and then we continue to lose over time, even if you're on contraception, even if you don't really have regular periods, we are losing eggs all the time as we age. Now, as we get closer and closer to that final period ever, what starts to happen is that your body is trying to ovulate, but we no longer have that many eggs, and our ovaries is where the eggs are, and our ovaries are what create most of our estrogen and progesterone. So if you think about your lifespan, and then you think about perimenopause specifically, your hormones are going to go down over time, but they don't happen in a linear fashion. They happen erratically, and they happen in an up and down fashion. So the name of the game that is perimenopause is ups and downs in hormones. So the ups and downs are to be expected. Changes in periods are to be expected. The extent of the change, question mark. It depends on who you are and what's happening in your body, and we can't predict it. And then you may have some symptoms, but not others. So some people have all the changes. So some people have hot flashes and night sweats and anxiety and insomnia and vaginal dryness and metabolic changes where they're putting on more weight in the midsection. They're having skin changes, rosacea, hair loss. Some people can have all the symptoms. Some people can have a grouping of symptoms. Some people have mild symptoms. Some people have significant, severe changes. And they, again, like the goal of perimenopausal support, if you are going through it, is to have you be supported in whatever way you need it. Perimenopause is a clinical diagnosis, meaning we are not looking at blood work to tell you that you're in perimenopause. We are going through your age. We are ruling out and testing you all around your hormones. So testing your iron and your B12 and your vitamin D and your liver enzymes and your blood sugar and your cholesterol and all of those sorts of things, making sure that those aren't contributing to how you're feeling and addressing them if they are contributing to how you're feeling, taking a look at, and then talking to you about your periods and if there's any changes, talking to you about the symptoms of perimenopause, and then we're making a diagnosis. That is how we tell you're in perimenopause. And perimenopause is not a disease. I also want to mention that perimenopause is a natural transition that we go through to our final period ever. And there's lots of life to be lived after menopause, which means that the better that we can support you in perimenopause, the better we also set you up for the future. Perimenopausal symptoms, when you have a lot of them, it affects your quality of life. And I want to go back to the original goal of this presentation, which was energy, mental health, mood, juggling responsibilities, and executive function, meaning your focus, your concentration, your working memory, meaning like the things that you keep in mind as you're doing a task. That's your working memory. All of these things can start to get influenced, not just because of hormone change, but also because of the symptom burden that you may have. If you're not sleeping well, if you're having hot flashes all the time, if you're super tired, if you are bleeding for 8, 9, 10 days of the month, that is all going to influence how you show up in your life. Plus, this is oftentimes when people are juggling a lot of responsibility, whether you are taking care of your work, your children, your family members, your aging parents, more responsibility out in the world, whatever it is, people are usually juggling a lot, and they find that the things that used to work no longer work. And it's because it's a sign from your body to tell you, excuse me, something needs to change. And something does need to change because as women, we tend to carry a lot of responsibility and we expect to carry that forever. But your body, when it starts to give you signs, and it usually starts with subtle signs, perimenopausal changes oftentimes will start with sleep and mood disturbances, not necessarily with menstrual cycle disturbances, even though by definition, it is defined by menstrual cycle changes. I think we're going to see a change in the definition. I'm speculating. I'm just going to warn you. I think we're going to see a change in the definition of how we define perimenopause in the next little while as we study it more. Perimenopause is severely understudied. We study menopause, we study fertility, we study perimenopause not very much, which is why people in their late 30s, early 40s get missed so often, and they're just told that it's stress, or they're told that it's anxiety or depression, when actually we're seeing the very real effects of hormone change and higher highs and lower lows of your hormones. As you can tell, I'm pretty passionate about women getting support because I really do want everyone to get support. Because, like I said, you have a long life to live ahead of you, and this is a time for you to actually make some changes and get some support. So perimenopause can last longer than you think. It is defined by changes in menstrual cycle, typically like if you're seeing changes of 7 days in your menstrual cycle. But the most common menstrual cycle changes that people start to experience is that they skip a period. They get their periods are closer together. Sometimes their periods will change not in length. So, for example, let's say you have a 6-day period or flow. It might still be 6 days, but you might have like one super heavy day and then it starts to taper off. It might be a little bit more erratic. You might get more PMS. You might get no PMS because you might skip ovulation some cycles because that is the natural progression of things as you get closer to menopause. We might not actually release an egg because of hormone change, but also because we don't have that many left. So that is the trajectory of perimenopause. Like I said, most of the time, the things that start to give us clues about perimenopause are age, and then sleep combined with sleep disturbances, mood dysregulation, and changes in energy and executive function. And this is also a time where we're generally in the peak of our careers, and this starts to really make people question, like, I just got here and I can't even function, or do I even want to do this? We don't want to make any hasty decisions. I really want people to be well supported in their symptoms because there are so many options for symptom management and to help you out that can really have you live your life to the best of your ability, but it generally will require some sort of change on your part. Okay, so I want to obviously leave you with lots of action tips, and here is where we start. Your best friend is tracking. Track your menstrual cycle, track it in an app, track it in a notebook, track it in your calendar. It really doesn't matter where you track it. But track your menstrual cycle. And if you've never tracked it before, then you really want to track your period. So when does it start? When does it end? And if you can make a couple of comments about your flow. So do you notice clots? Clots that are bigger than a toonie are not normal unless they're happening occasionally. An occasional change in your menstrual cycle, an occasional change in your pain, and occasional change in your length, we're not so worried about. But when it becomes a trend, it is usually because something else is happening and we should figure out why. So track your period first and foremost. If there's one thing you're going to track that. Ovulation. So ovulation, generally, you'll have a little bit more cervical mucus, like I was saying. You might even get like a little bit of a twinge or a pain. Some people get sort of digestive symptoms and or spotting, which actually can indicate maybe you have a fibroid or you have IBS or you have endometriosis, something like a different conditions. So ovulation sometimes can come with symptoms. If the symptoms are severe at ovulation, again, we're likely looking at something going on underneath. And then premenstrual changes. What are you noticing in the lead up to your period? Are you noticing a lot of anxiety, insomnia? Are you experiencing a migraine, for example? Because there is such a thing as menstrual migraine. When estrogen drops, it can trigger a migraine in some individuals. So track whatever is happening. And then anytime you start to see things that come up sometimes but not at other times, or something that is new, this is a great thing to track along with your menstrual cycle, because if there is a relationship with your menstrual cycle, you will know and you will see it because you're tracking it. And if there's not, it still gives us valid information. It tells us about the frequency, it tells us about the intensity. And if you can actually write down like some of the specifics, meaning if you can write down that your pain was on at a 6 out of 10, and you missed work, and you had clots that were bigger than a toonie, that is actually information that is relevant. And then you can say, I took 5 extra strength Advils. These are the kinds of things that help us put together a case and an assessment, because a lot of hormone-based conditions, we have to listen to you to in order to identify what the next step is and how we support you, and sometimes even to diagnose. So yeah, the timing, trigger, and toll, that's what I say. If you have hormone-based symptoms or changing symptoms, or symptoms that just come up every now and again, that's what you want to actually pay attention to and note down. Our brains have a lot to think about and our memories are imperfect. So please write it down. And then the foundations always matter. So what I mean by this is like all the things that you do on a regular basis, all the things that we know, most of us know that are good for us, like drinking enough water, making sure you get your blood pressure checked, your iron tested, and then actually taking your iron supplement. Iron deficiency is the most common global deficiency in menstruators. And without iron, you can't grow hair, you feel tired, you feel sluggish, you have more brain fog, and you cannot concentrate. So, getting your testing done, eating well, exercising regularly, moving your body, taking care of your mental health, sleeping properly, taking care of whatever you need to take care of, meeting up with your people, spending a little bit of time on the things that you love and enjoy. Because one of the most common things I hear from my perimenopausal and postmenopausal patients is that I don't even know what I like doing. I spent all my time on other people, on my kids, on my work, on building my career, on my partner, on my family, on my friends, and I don't even know what I like anymore. There's a lot of identity shifts that happen in this time, and we actually need to support all parts of us in order to not only feel well, but also to decrease the impact of those hormonal fluctuations. We know that when we take care of our mental health, we know that counseling can actually help with sleep problems, can help with vasomotor symptoms, which are the hot flashes, night sweats, and can help with mental health in this time. So we actually do want a multifaceted approach, and I understand not all of us can do all of the things, and your ideal way of doing things might not be feasible, but whatever you can do, even if it's small, it makes a difference. Because here's how I describe how your body is responding to hormone change. If this is where you are at, and this is where you feel best, you are going to feel hormonal fluctuations way more down here. Your threshold of tolerance is going to be very different down here than up here when you're hydrated and you've eaten 3 meals and you've also, talked to a friend this week or whatever it is. So this is where we want you to be. We want you to actually have some of those foundations, in place, so that we see where you're at with some of those foundations, but also that volatility of hormones doesn't impact you in such a volatile way. And then there's always a difference between active treatment and prevention. I put this slide in and titled it this way because online is where we get a lot of our information, and online it's difficult to gauge who is a real vetted expert and who is sort of trying to sell you things. Okay, I'm getting a cue to wrap up, so I'll wrap up with this essentially. Managing it, if you have a diagnosis, if you have a condition, if you have like active symptoms, treating that may look different than you not having a condition, but wanting to improve your health for the long run, right? Someone who has osteoporosis versus someone wanting to maximize their bone health, we support them a little bit differently. Someone who has osteoporosis needs more active treatment versus someone who wants to really make sure that they don't get osteoporosis or decrease their chances of getting osteoporosis, right? Prevention is a little bit different than active treatment, but the way that we manage hormone-based symptoms includes contraceptives. So Mariam and Nafisa talked a little bit about IUDs and other hormonal contraceptives. Those hormonal treatments are still valid and can be used in perimenopause to decrease bleeding, to help with pain, and also to protect your uterus against cancer if you are taking something like estrogen. We have hormone therapy, which can look like vaginal hormone therapy or transdermal estrogen, patches, oral progesterone. It can look like a lot of different things. There's herbs and supplements that we can use, topicals based on what's going on, physical therapies, specific skincare if your skin is changing, acupuncture, medications. There is a wide range of things that we can use to support you in perimenopause. But what we use with you depends on your values, your goals, what's happening in your body, what else is happening in your health. But the main thing I'll say here is make sure you get your routine testing, because when it comes to energy, mental health, mood, and focus and concentration, bringing it back to those topics, iron deficiency, B12 deficiency, vitamin D deficiency, and eating regularly throughout the day and making sure you're sleeping. These are the 5 foundations that make the biggest difference and will still apply even if you're in perimenopause or menopause. And this is the final slide on self-advocacy. So try to go prepared with appointments. Family doctors, as we all know, have a high burden of responsibility in a short amount of time. If you can make your concerns super specific. So I've noticed that my periods have gone from 2 days to 5 days. I'm bleeding. I'm leaking through my pad in the evening. I'm also noticing a pain on a scale of 10. It's at a 6, and I'm also not sleeping at night. And I'm noticing my anxiety is at a 6 out of 10. If you can be specific, it will help them help you better. If you can take someone to appointments to facilitate a more productive visit, that's also helpful. Ask questions. I know sometimes, especially I remember growing up in Pakistan, like we defer all power to the doctor, whereas we can ask questions. You can ask for clarification. You can ask for resources. You can ask about referrals to specialists. You can ask them like, how long do I do this? And what do I expect to see on this medication or treatment? And if we're not doing anything right now, when do we reassess? All of these will give you a little bit of the power back to direct your appointments. And here are some resources. I'm hoping that the team will send them out to you, but these are some vetted resources that you can take a look at. I obviously make a lot of resources myself, and a lot of them are informed by the conversations that I have in clinical practice. And if you have any, I know we rushed through this a little bit and it was very broad, but if you do want to ever get in touch, that's my personal email on there. You can also reach me through my website. And that's it.
Wow, thank you, Anne. I think that was phenomenal. You went through so much in such little time. And Anne, as you were speaking, I was just reading a great saying, and it said, be the person you needed when you were younger. So, I feel that I wish I could have connected with you when I was going through perimenopause and menopause, but I didn't. But I'm happy that we have our members and attendees here who have access to you and to Action Canada for some great resources and for some great tips. So thank you so much. What I walked away with, be aware of your hormonal health, document, everything that you're seeing, small and big, and be proactive, right? Like, that advocacy piece is so important, because coming from South Asian countries, sometimes we say the doctors know it all, but they have so many patients, they are, so they have their own dilemmas to deal with. So I really like that be proactive around your health. Again, a big thank you to you for taking the time and for explaining all these wonderful things to us. And back to our attendees, I would just say before we go to the Q&As, we just have a very, very short survey. I will hand it over to Iman. And this survey is basically just 2 or 3 questions, again, to know what you would like to see in future sessions. So Iman, over to you, my dear, if you can just take us through that poll.